Hi, good morning, everyone, and welcome to our Ask the Expert series. We're pleased to have Dr. Alexander Vodenovich here with us today to give his talk on sleepy days and restless nights of Parkinson's disease. Dr. Vodenovich is an associate professor of neurology at Harvard Medical School and director of the Division of Sleep Medicine at MGH and director of the MGH program on sleep, circadian biology, and neurodegeneration. His clinical activities include the diagnosis and treatment of a wide spectrum of movement disorders and coexistent sleep dysfunction associated with these disorders. Dr. Vodenovich directs a clinical and research program on REM sleep behavior disorder at MGH, and his research programs are focused on the interface of sleep, circadian biology, and neurodegeneration, as well as on clinical trials in sleep and neurodegenerative disorders with an emphasis on Parkinson's disease. Thank you so much for being here, and I'll turn it over to you to begin your
talk. Well, thank you very much for this introduction, and good morning, everyone. It is really my pleasure, and I appreciate this opportunity to tell you a story about sleep and sleepiness in Parkinson's disease. And I view this topic obviously as very relevant to quality of life of our patients with Parkinson's disease, also their caregivers and their families. So I will start by recognizing the fact that Parkinson's disease is obviously very prevalent medical condition worldwide. And this is just to escalate, as we estimate that by the end of this decade, the number of cases of Parkinson's disease will double in the most populous nations on the planet. So therefore, we are dealing really with epidemic proportions of nations being affected by Parkinson's disease. This condition was initially described by this English physician, James Parkinson, and he described clinical descriptions of his initial patients that he was seeing in his practice in England, and put this together in a famous essay on the shaking palsy. That's how he called it Parkinson's disease initially. And subsequently, it was Charcot from Paris who named this disease after him later on, and the disease became known as Parkinson's disease. Well, if you read this essay on the shaking palsy, which was written and published now over 2 centuries ago, you run into descriptions of sleep problems that have been really very astutely described by this clinician 2 centuries ago. And here are 2 quotations or quotes or excerpts from this monograph that clearly illustrate that patients with Parkinson's disease and their sleep troubles have been recognized even then, again, 2 centuries ago. Many years and decades and centuries actually have passed, and took us a long time to take an active approach and think and recognize how big issue sleep and alertness during the daytime how big issue is for patients with Parkinson's disease, for their bed partners, for their caregivers, families. And luckily we understand that today, but this attention to sleep issue in Parkinson's disease really has emerged probably over the past, I'd say, 2 decades or so, not so much earlier than that. And for all this time, most of these 2 centuries, our emphasis has been on Parkinsonism and motor symptoms of the disease, tremors, slowness, stiffness, etc. And those are all symptoms that are due to changes that are occurring in substantia nigra, which is a part of the brain that contains a lot of dopamine and which is important for the coordination of the movements, and whose dysfunction give rise to these motor symptoms of the disease. And here you see this is this iceberg, right? And on the tip of the iceberg was just this Parkinsonism, and the rest of the iceberg, which is so much bigger, almost 90%, are these other anatomical areas that are also affected in Parkinson's disease, and that have not been so much recognized for the most of these 2 centuries that we are dealing with this disease. But luckily, that has changed, and this iceberg now is melted, because we now appreciate and study and try to treat symptoms that are emanating from all of these other anatomical areas of the brain that were not recognized initially. And this is here one of the cartoons that I like, which is not the case anymore. We understand that Parkinson's patients may have a lot of troubles. There may be a depression, constipation, motor symptoms of the disease, problems with smell, sleep disorders. And we as a physicians are not so much blindfolded and focusing only on one symptom of the disease, but rather are approaching this Parkinson's complex as a really a myriad of symptoms and signs that need to be addressed in a coordinated fashion and that are related to each other. So today's talk is about sleep, and I want to give you some basics. How is our sleep organized? You may know this, but I like to start with this, so that because I'll use some terminology in this talk, and you should be familiar with this terminology. First of all, sleep evolves overnight, right? Sleep is a very complex state, and we are really unresponsive during that sleep. And we can say that there are 2 main stages of sleep, and this is non-REM sleep and REM sleep. And REM stands for rapid eye movements, right? So there are a lot of these eye movements in a REM sleep, and a non-REM sleep does not have these movements. But in general, there is a non-REM sleep and there is a REM sleep. And sleep has its own architecture, its own structure, right? Here you have the example of this sleep architecture. You see here, as the night goes on, and we start sleeping somewhere here, and then the night goes on, and we have 6, 7, 8 hours of sleep. You can see that all of these sleep stages that are here depicted in these colored bars are changing, right? So these bright colors are stages of non-REM sleep. So bright colors represent non-REM sleep. And these black lines here, black blocks, those are blocks of REM sleep. And you can see that as the night goes on, that REM sleep becomes more frequent, and that certain stages of non-REM sleep slowly disappearing, and that non-REM sleep is much more present initially when the night is young, and then in the second half of the night, you can see that architecture is quite changed from the beginning of the night. So these are some basic aspects of sleep physiology and how is sleep structured. So as we age, whether we are healthy or we are dealing with the various medical conditions, invariably sleep will change, just as a function of aging. There will be changes that are occurring in a sleep staging and sleep architecture. And here you see a sleep stage in a younger individual, and then how it is changing in older patients, in older adults, not only patients. Our sleep becomes less efficient as we age. There are more nighttime arousals. There is increasing napping during the daytime, and there are coexisting problems with sleep disorders that are starting to emerge as we age. And here you can see from a baby to adulthood to older age that these graphs here look very different. See the number, babies sleep a long period of their 24-hour, right? Much more than a half a day. You can see how the number of awakening increases as we age. And in older age, you see all of these fragmentations of sleep that are occurring. And that can be just a function of aging. So now we can start to talk about sleep problems in Parkinson's disease. I always start by saying that this problem is underdiagnosed by us healthcare professionals, but also underreported by our patients and their caregivers. And this is very important to stress out because we all can do a better job by a timely recognition and appropriate treatment of these sleep problems. The other challenge when we talk about management of sleep problems in Parkinson's stems from the fact that Parkinson's patients represent very heterogeneous group of patients. So I like to say that there are no two PD patients alike. There are different troubles that patients perceive or have. And therefore, in this heterogeneity, sleep problems also can be very different and heterogeneous, which causes challenge for the proper assessment, diagnosis, etc. And I'd like to say that when we talk about the etiology of sleep problems, that there are many possible causes that can result in impaired sleep and alertness. And if one doesn't spend enough time of thinking what may be causing this impaired sleep and alertness, we may not get to the root cause and therefore may not be best positioned for the treatment of these problems. And this graph here illustrates this problem, right? What I was just saying. You have this nice system of sleep and alertness, which is a nice balancing act. And obviously, there are some important processes that regulate that nice balance of sleep and alertness. And these processes, the circadian process and homeostatic process, certainly are affected by the neurodegeneration of Parkinson's disease, right? There are brain changes. There are brain changes that are affected areas that are regulating sleep and alertness. And that can cause that this nice balancing act is not so nicely balanced anymore. But then outside the realm of these effects of Parkinson's disease itself, there are many other, for example, primary sleep disorders or other causes of Parkinson's disease that are influencing sleep and alertness. And that's why I like to say that the landscape is a very complex here and a very dedicated time should be devoted to discussing and managing these sleep problems in Parkinson's patients. We can say that for the lifelong duration of Parkinson's disease, almost every patient will at some point experience one or another type of a sleep trouble. And in general, I like to dissect these sleep issues and talk about problems with the nighttime sleep, obviously, but also problem problems with alertness during the daytime that go hand in hand with the nighttime problems. So what are these nighttime challenges that patients have with their sleep, right? Well, patients may develop emergence of motor symptoms as they wake up in the middle of the night. Patients may, for example, have sleep apnea. There is a condition, REM sleep behavior disorder, which is very common in Parkinson's patients. There are either periodic limb movements of sleep or restless legs syndrome, which I'm sure you heard about, that can be also nighttime sleep disturbances of our patients. And there are many other causes that can also be considered as important factors for poor sleep at night. So whenever we talk about healthy sleep, we use this terminology, sleep hygiene, right? And I'd like to start with that and explain what is in the name of that sleep hygiene, and that's why we are mentioning it, right? This is something that we should all adhere to, right? This is like washing your hands, brushing your teeth. This is taking a shower. This is what we really need to do in order to improve our sleep. If possible, we shouldn't take excessive naps during the daytime. Exercise should really not be happening just before the bedtime or in the late evening, because it can alert us too much and then we can have trouble sleeping. Bedroom should be used to sleep. And really all these other television and devices and computers, we should avoid using this when we are in the bed. Caffeine and alcohol should not be using later in the day because it will have problems. They will cause troubles with falling asleep and staying asleep. And obviously, patients with Parkinson's have a lot of problems with getting up and needing to urinate overnight. And therefore, restricting some fluid intake just before the bedtime can provide a big difference. So these are some sleep hygiene principles I wanted to discuss upfront at the beginning of this call. I also would like to talk to you a little bit about the effects of dopaminergic medications on sleep. Dopaminergic medicines that are used in the management of Parkinson's disease may have both alerting and soporific, sleepy properties, right? And therefore, it is important that if one has difficulties with falling asleep or staying asleep, that medication regimens be very, very carefully reviewed. I would also like to mention that use of some of the medications used in the treatment of Parkinson's disease can be very helpful for the management of nighttime sleep. For example, here you see several clinical trials, Cleopatra PD, EASE PD, Recover. And in all of these trials, we use dopamine agonists. And through these studies, we know that these dopamine agonists help improve sleep quality. However, the same class of drugs, dopamine agonists, can cause a lot of sleepiness during the daytime, even cause sleep attacks, which is obviously the challenge for the patients with Parkinson's disease. So this is an illustration of how the same class of drugs can have variable effects on daytime and nighttime function when it comes to sleep and wake cycle. So let's now talk about common problems with sleep. And I start with sleep fragmentation. This is the most common problem that patients have when it comes to their sleep. We know that patients usually can fall asleep without problems, and you probably can relate to this. Most of you will tell me, I go to bed and I fall asleep without problems. But then subsequently, I keep waking up, and that may be every hour, every 2 hours, and sometimes I can go back to sleep, but sometimes I cannot. Or there is a scenario where you fall asleep nicely and then you wake up after 4.5 hours, and that's it. It's early morning. You really cannot go back to sleep anymore. So this is a big problem because we need a good night of uninterrupted, consolidated sleep. And these are some of the causes for this sleep fragmentation. As I mentioned, sometimes there is emergence of PD-specific symptoms, tremor, rigidity, and ability to move and turn in the bed. Sometimes dyskinesias or dystonic painful spasms can all cause that our sleep become fragmented. Need to get up to use the bathroom. Or, for example, have coexistence of other sleep disorders, such as sleep apnea or restless leg syndrome, that are not diagnosed appropriately or treated effectively. All this can cause problems with fragmented sleep. So what can we do about that, right? What can be done to manage that sleep fragmentation? Well, I would say that it's important to consider using dopaminergic medicines in some cases if there is emergence of motor symptoms at nighttime, if there is a Parkinsonism that is problematic during the nighttime, then one can consider these three first bullet points here, where we are trying to add some of the dopaminergic medicines before bedtime. Traditionally, I do not use dopaminergic medications overnight. I don't prescribe Sinemet or dopamine agonists to be taken before bedtime routinely. But if patients are endorsing that symptoms are so prominent during the nighttime, then I consider doing that. And for example, at that time, I may consider prescribing long-acting levodopa or long-acting Sinemet, which I traditionally do not use in the management of daytime symptoms. I don't use long-acting formulations. I use mainly immediate release preparations of levodopa during the daytime. Then there are medicines like selagiline or amantadine that really have alerting properties, and they should really be not given late in the evening or at bedtime. I always suggest that taking fluids, it's always good. And I suggest that we all need to be well hydrated. However, if one struggles with a lot of problems with autonomic dysfunction and need to use the bathroom at night, one should minimize the fluid intake before bedtime. And certainly water pills or diuretics should be saved for earlier in the day. There are some medicines that one can use for bladder problems, such as anticholinergics, and usually I let my patients discuss that with their urologist. And these last two bullet points I cannot emphasize enough. Patients with Parkinson's frequently have mood symptoms that may go unrecognized and untreated. And these symptoms can be the sole and primary reason of poor sleep of our patients. Furthermore, patients may also have other sleep disorders, such as sleep apnea, that have not been diagnosed, or if they are treated, they may not be treated appropriately. And therefore, special attention should be devoted to coexistent comorbid sleep and psychiatric disorders and its treatment. Now I'm going to move to another disorder, and this disorder is known as a REM sleep behavior disorder. So what's in the name here? REM sleep behavior disorder, right? I told you about REM sleep. I told you that that's one of two main stages of sleep. And during this sleep, we frequently dream. Whether we remember or don't remember those dreams, that's a different story. When we enter REM sleep at night, as we sleep, our body becomes paralyzed, except the breathing muscles that enable us to continue to breathe throughout that REM sleep. In this condition, REM sleep behavior disorder, for some reason, that paralysis of our body does not take place when we enter REM sleep, which means that we can move as we are going and dreaming through that REM sleep. Another piece of these disorders are these very vivid dreams, very frequently active dreams, and very aggressive dreams, in which we are trying usually to escape some very frightful situation. For example, we are being attacked and we need to defend themselves, or we just need to escape a fire or some other emergency. And now you can imagine, as you dream that you are being attacked, you start in your dreams to fight. And now, since you can move because your body is not paralyzed, you are really fighting out in the bed in the middle of the night. You are acting out that dreams. And as you can imagine, as you hit and swing and do all kinds of things, you can hit your bed partner, you can hit the wall, you can fall out of bed. So this is what this REM sleep behavior disorder is about. These are some of the diagnostic criteria, and they summarize what I just told you, what this disorder is about. We usually can get a good report from our patients and their bed partners, in most cases, what's going on at night. But we still like to bring these patients to the sleep laboratory so that indeed we can trace their sleep on a monitor and see that when they enter REM sleep, that indeed they do not become paralyzed, that there is a still ongoing muscle activity, because we can monitor that muscle activity as you sleep in a sleep laboratory. And this is how that sleep recording would look like. Here on this slide, you see all of these lines, and this entire image here represents 30 seconds of someone's sleep. And here at the top, you see a lot of eye movements, these lines that are going in the opposite direction. Then you have some brain waves here. Then there are some lines here that I'm showing you that are actually representing muscle activity. And then there is a breathing signal at the bottom where you see nice breathing in and out. So I want you to focus on the center of this image where you see these lines, right? Horizontal lines. And those are recordings from your leg muscles. See your right leg and your left leg. And this 30 seconds of sleep is representing REM sleep. So patient is now in REM sleep. And as I said, when we enter REM sleep, our muscles should be paralyzed. When we have REM sleep behavior disorders, our muscles are not paralyzed. And this later scenario we are seeing here, because if muscles are paralyzed, these lines here should be completely flat, just like here. But for these patients, you see these bursts of activity here on these two channels from right and left leg. And each of these bursts of the activity here, each of these vertical lines represents muscles being active. Maybe this patient is moving or kicking his legs as he is dreaming. And this is why we bring patients to the sleep laboratory to indeed demonstrate that patients have this muscle activation during REM sleep that should not be there in normal circumstances. Why is this REM sleep behavior disorder very important? It is of critical significance for Parkinson's patients because this sleep condition is one of the earliest indications that patient may be on the way of developing Parkinson's disease. And these studies here that I listed here for you are illustrations of that. In 1996, this was recognized for the first time, where our colleagues from University of Minnesota reported and observed that in a group of patients who had only this sleep disorder and nothing else, almost a third of them went on to develop a Parkinsonian condition. And when they followed those patients later on in 2018, that number has risen to over 80%. And there are a number of studies that have now documented that these individuals who are diagnosed with REM sleep behavior disorder, as they continue to live their lives, in large proportions of them, there will be emergence of either Parkinson's disease or other Parkinsonian conditions such as dementia with Lewy body or multiple system atrophy. And that's why this REM sleep behavior disorder is very important. And we do a lot of clinical care and have a research on REM behavior disorder because these patients are in the very early stages of neurodegeneration. When that dopaminergic system that I show you at the beginning is not so severely affected, and it will be years before that dopamine loss intensifies and before the patients start to develop one-sided tremors or some stiffness on one side and are finally diagnosed with Parkinson's disease. So this is important because as new trials for Parkinson's disease become available, we may be able to use these RBD populations to test these medications and hopefully arrest the progression of that neurodegeneration that ultimately leads to emergence of motor symptoms that are needed for the diagnosis of Parkinson's disease today. What can we do for the management of REM behavior disorder in patients who already have Parkinson's disease? The most important aspect is that we need to assure that patients understand what this disease is and that there are safety protective measures that they implement in their sleeping environments, that there are no sharp objects close to their head, that beds are padded by pillows against the headboard, and that their bed is not very tall. So if somebody rolls out of bed, that they don't have great chances of being injured. When we implement these other measures, we can use basically two types of medications to treat this condition. We can use over-the-counter melatonin, which is very effective, or we can use Valium-type drugs known as benzodiazepines, and clonazepam is one of the drugs that is most commonly used. Or sometimes we use combination of clonazepam and melatonin. A lot of patients are now being treated with antidepressants for mood symptoms. And I'd like to point out that some of these antidepressants may worsen or unmask these REM sleep behavior disorder symptoms. And therefore, it's important to be vigilant and maybe make some changes in these antidepressants so that chance for worsening RBD or provoking the symptoms of RBD in patients with Parkinson's disease is less. These are various studies that I have put here. I will not go over it. The bottom line is really that only these two classes of drugs that I mentioned are effective that we know up to date in the management of RBD. Now I'd like to talk about restless leg syndrome, which is another primary sleep disorder which may affect nighttime function and sleep. So this is a condition in which individuals start to feel uncomfortable, unpleasant sensation in lower extremities, usually in the evening hours as they sit to watch TV or read a book. They may feel some creepy crawly sensation over their legs, and that causes an urge to move legs. And sometimes it's present in the arms as well. And then patients need to get up and walk around. This results in the transient resolution of these symptoms, But as soon as patients resume their sedentary position, these symptoms reemerge. So this is really what restless leg syndrome is. How common it is in a Parkinson's disease, we really don't know well. And here you see the prevalence being anywhere between 0 and 50% of patients affected with Parkinson's disease. But it's very challenging to study restless legs in Parkinson's disease because symptoms of Parkinson's disease itself may mimic this restless leg syndrome. As you know, some of you may feel a restlessness that has nothing to do with the restless leg syndrome that's associated with Parkinson's disease. Sometimes stiffness or rigidity that emerges in the evening can also be perceived as a restless leg syndrome. And therefore, I have many patients who come and tell me, and you know, I have that restless leg syndrome as well. And then we talk about that, and it turns out that really, it's really not a restless leg syndrome. So another interesting aspect of restless leg syndrome is that, and another good aspect, I think, is that medications that we use for the management of Parkinson's disease can be effective in managing restless leg syndrome, with the exception that if someone has only restless leg syndrome, the amount of medicines that we would give would be many, many times less than what we would need to treat Parkinson's disease. There are other classes of drugs that are used to manage restless leg syndrome. Those are like these benzodiazepines, like clonazepam, for example. These calcium channel ligands, that's like a neurontin, or gabapentin and pregabalin. And sometimes in a very refractory cases, we will use opioids, but that's really saved for individuals who we cannot manage in any other means. And obviously there are challenges with prescribing opioids, but they can be very effective in the management of restless leg syndrome. One should avoid the medicines that we would avoid in cases of Parkinson's disease, for example, dopamine blocking agents and some other classes of drugs that can exacerbate restless leg syndrome. Now I will speak a little bit about sleep disorder breathing. When I mean sleep disorder breathing, the prototype of the condition is really sleep apnea. And initially, we thought that sleep apnea is more common in Parkinson's patients than in a regular population. But now we know that that's not the case. We believe that Parkinson's patients have the same chance of getting sleep apnea as general population. When we talk about patients with the sleep apnea and the prototype of that patient, we would usually think about obese male with a large neck size, a lot of obesity, and that all that tissue, excess tissue in the throat area and excess obesity in the abdomen causes challenges during sleep, closure of the airway, etc. With Parkinson's patients, that may be a little bit different. Usually patients with Parkinson's disease are not obese, and due to issue of neurodegeneration and brain changes that affect areas of the brain that regulate sleep and breathing, the problem with apneas may not be only related to the throat closure due to local anatomical characteristics, but also can emanate from the brain regulatory centers, and therefore we may have not only obstructive apneas, which are most commonly reported apneas, but it can be central apnea as well. Central pause in breathing that is directed from the brain rather than from the throat closure. And here, and the most common form, as I said, is a sleep apnea syndrome. And the most common scenario is that all of this throat tissue here with a large tongue that falls back as we are in a supine position really can close the blockage of this air that needs to go into the lungs. And there is a closure of that airway here, and therefore not enough oxygen is going on into the lungs, and ultimately, when that level of the oxygen falls down quite significantly, we need to wake up and suddenly gasp for air. So these are treatment choices that we have in the management of sleep apnea. Obviously, this positive airway pressure, this PAP therapy, is the most commonly used treatment modality. There is a machine that is connected to the patient via this face mask interface, and this machine really blows the air at various different pressure level, and then we try to decide what is the optimal pressure of pressured air that machine needs to create to overcome this closure that is happening in the throat. There are some other approaches as well, especially for individuals with mild apnea, avoiding sleeping in a supine position, weight loss, very important for patients with a BMI over 30, using a dental appliances that reposition your jaw, and that way try to help the flow of the air. And in some cases, there are also several surgical treatments that one can undergo in the management of sleep apnea in the very severe cases, where mainly these other treatment approaches have not been effective. So far, I was telling you the story about the nights of patients with Parkinson's disease, and now I will move to daytime function. And I start by this study, which is now an old study, but it's a study that brought this excessive sleepiness to the eyes of medical professionals and patients and the public. Frucht and colleagues from Columbia University in New York reported in early 90s, there are patients who were treated with dopamine agonists. And these patients, some of them have experienced episodes of sudden onset sleep at the wheel while driving. And that's what started this story of excessive daytime sleepiness. They coined the term of sleep attacks, as these patients were developing overwhelming sleepiness that could really not be overcome by patient's will. And since then, we have paid more attention to alertness of patients with Parkinson's disease. And here you can see some epidemiological reports which indicate that sleepiness is much more common in Parkinson's patients compared to general population or some other chronic disorders. This issue is very important from the safety perspective. This is one study from Germany, which studied patients with Parkinson's disease who have a driver's license. You can appreciate that 8% of them experienced sudden onset sleep at the wheel. And what's even more frightening is that half of those patients, only half of them had the warning signs of sleepiness, and 26%, quarter of them, suddenly fell asleep at the wheel without even a hint of a warning. So obviously, this is why we need to think a lot about sleepiness during the daytime. This is a complex problem. And these are some of the causes that can drive this sleepiness during the daytime. I mentioned that these dopamine agonists really have property to make patients asleep in up to 30% of patients. There are other sleep problems that are maybe not treated, like sleep apnea, causes a lot of daytime sleepiness. If it's unrecognized and untreated, you know, sleepiness cannot be appropriately treated either. And obviously changes in the sleep architecture as we age, and changes due to this degeneration of these brain areas associated with Parkinson's disease also can negatively affect this alertness in Parkinson's patients. So how can we assess the degree of sleepiness? The critical element is that we must get an information from family, caregiver, spouse, because patients frequently under-recognize the degree of their own sleepiness. A review of the medication regimen is obligatory because we need to address and eliminate soporific medications from the list of drugs that patients are exposed to. And then we can bring patients to the sleep laboratory and test their alertness during the daytime, or we can give them various scales that measure degree of sleepiness, various questionnaires, and quantify what the degree of daytime sleepiness they actually have. In terms of the treatment, sleep hygiene is very important here because we really need to get a good night sleep in order to be functional the following day. Primary sleep disorders have to be recognized and treated. Soporific medications should be adjusted, eliminated, or at least minimized if we cannot get rid of them. There are some medicines that are used to boost alertness. Initially, we used stimulants like Ritalin, for example, but we don't use that class of drugs anymore because of some potential side effects. Modafinil is the medication that is frequently used to manage sleepiness, but with some mixed results. And there are these other approaches that are being tested, such as use of caffeine. Patients who undergo deep brain stimulation may report better alertness during the daytime. And either a sodium oxybate that is used for the management of narcolepsy, which is another primary sleep disorder associated with hypersleepiness, is being now explored to be applied and used to manage excessive sleepiness in Parkinson's patients. And towards the end of the talk now, I'd like to switch and tell you a little bit about circadian system, which has been a focus of our work here for a while now. What is the circadian system? This is actually our timing system. Deep in the brain, we have our internal clock, which is known as a suprachiasmatic nucleus. What does that mean, suprachiasmatic nucleus? That is a group of nerve cells that is located in one area of the brain, and they act as a pacemaker, as a timer for our other brain areas or for all of other organs. So every cell in our body, believe it or not, has its own clock. And it is this master clock from the brain that coordinates the function of all other brain clocks that are in other brain cells and all other clocks that are in the heart and the liver and the lungs and other organs, right? And that's why we call this suprachiasmatic nucleus, this group of nerve cells, our clock, our pacemaker. The job of this pacemaker is to align function of our body with the rotation of our planet. You all know that we go through the dark and light cycles, and it is the job of this clock to keep us aligned with this day period and the night period so that we can function as a social individuals, that we can go to bed when we need to go to bed and then wake up in the morning when the light comes on, go to work or to school and do our jobs. So in order to do that, this clock needs some signals, some stimuli from the outside world, and light, sunlight, is the most important stimulus to this internal clock to help him align us to the day and night periods. And in addition to light, which acts through eye, through retina to be specific, which is connected to our internal clock, there are other time cues, for example, physical activity, or even meal times, provide an information to internal clock, what period of the day it is, and then the clock needs to arrange and make sure that all other clocks in the body are synchronized to the central clock, to the central pacemaker. So we are doing a lot of work on significance of light for patients with Parkinson's disease. And we are trying to understand how light, through its effect on our body, can affect the physiology and behavior, which is nothing more than symptoms and signs of patients with Parkinson's disease. And this is one of a study that we have done, it's been a while now, where we applied light therapy using this light box to patients with Parkinson's disease for 2 weeks and try to judge whether that intervention has positive effects on daytime alertness and sleep quality at night. And indeed, we have demonstrated that after only 2 weeks of this light therapy, patients have been able to consolidate sleep better, reported better sleep quality, and also had a better function during the daytime. And after this study, we have started to do many other clinical trials and other investigations to try to understand the function of circadian system in Parkinson's disease, and more so how we can apply light therapy to manage not only sleep and alertness problems in Parkinson's disease, but other problems that patients may have, other non-motor symptoms, such as mood disorders, anxiety, fatigue. And some of the studies that have been done with light in Parkinson's have also demonstrated positive effects on motor symptoms of the disease. So we currently have a number of studies that are focused on this area of research. I'm leading the US-wide study at 25 sites across the United States that is centered on a dose selection. What is the appropriate dose of a light therapy for sleep in Parkinson's disease? And my dear colleagues at Beth Israel are one of the clinical, leading one of the clinical sites at Beth Israel Hospital. This recruitment for this trial and for other studies here at MGH is now ongoing. So if you would like to get more information about the studies and if you're interested to participate, your contact would be Samantha Murphy. She's our senior research coordinator and can be reached to this number and this email. We would love to hear from you if you're interested to join and partner in some of our research projects that we have. So I show you this slide that you have already seen at the end of the talk because I just want to illustrate that there is a lot to talk about sleep and alertness, that there are many angles from which we can act to improve these problems if you have them. And I encourage you to talk to your providers who take care of your PD team, because they can direct you in and help a lot. But we first need to recognize the problem in order to address it appropriately. And in a concluding remarks, I would like to say that it's important to apply the sleep hygiene principles. I emphasize the role of prompt diagnosis and management of coexisting primary sleep disorders and psychiatric disorders. The half of the problem is just to recognize and properly diagnose the sleep issue, and then the treatment paradigm can be much better defined. And one can do a lot to improve sleep. And And a lot outside the medication realm. We can do a cognitive behavioral therapy. We can do various medications, but also use some other non-pharmacological therapies, these circadian-based therapies, such as light exposure, measuring, monitoring, changing the light exposure, and also doing various exercise routines. So this is all I had prepared for you this morning. Thank you again so much for joining us. I hope that we can make a change in your function during the daytime and also improve your nighttime sleep. So again, thanks so much for the invitation, and I'll be happy now to take any questions that you may have for me.
Thank you so much for your talk. We do have a number of questions. The first one here in our Q&A section is, what is the recommended dose of melatonin that you normally recommend?
I would usually start at the dose anywhere between 3 and 5 milligrams at the bedtime. I prefer to be taken about 30 to 40 minutes before bedtime. And usually these are strengths that you can easily find over the counter in any of the local pharmacies. So 3 to 5 milligrams is a starting dose.
Great. And then we received another question asking you to further explain REM problems, so acting out in dreams, and later risks of dementia that are associated with that.
Yeah, so as I say, for the REM sleep behavior disorder, the hallmark of the disease is that patients are actually acting out their dreams, right? And whatever they are dreaming about, they are acting in their bedroom. So I had a patient, for example, who said, "Doctor, in my dream, I was standing at the edge of the swimming pool. It was such a beautiful pool, and I was just ready to dive in. And the next thing I know, I'm waking up, bruised with my forehead on a hardwood floor next to my bed." So he dived out of bed, re-imaging that dream imagery, reliving that dream imagery that he was jumping into the pool. So now let's talk about the risk of developing one of those disorders, which can be Parkinson's disease, or for example, dementia with Lewy body, in individuals who have a REM sleep behavior disorder. I like to quote two numbers. One number is that annual risk for development one of these conditions on an annual basis is about 7%. Another study that I like to quote is this study in which they followed patients with REM sleep behavior disorder, and among individuals who have had that disease for 10 to 12 years, about 50% of them developed either Parkinson's disease or dementia with Lewy body. You will find the various numbers in the literature. These happen to be something that I like to quote, so I hope this answers your question.
Great. And then we received a few questions about DBS and sleep. So the first one here is, if you could explain a little bit more about DBS and daytime sleepiness.
So what we believe, when one does DBS, right, these are usually patients who have some motor fluctuations, wearing off symptoms. They are a little bit more advanced patients with Parkinson's disease. And a lot of these motor symptoms of the disease become better regulated with the deep brain stimulation. And these individuals can have a better nights of sleep and less daytime problems, I believe definitely through the modification and improvement of motor symptoms that have been achieved through deep brain stimulation. It is also possible, but less explored, if and how deep brain stimulation can affect the function of these sleep-wake regulatory areas of the brain through various circuitries. I think that is a possibility, but that is much less known. So we believe that optimization of sleep and alertness after deep brain stimulation is driven through its positive effects on Parkinsonism.
And so in that similar vein, another question is, have adjustments made to DBS controllers improves the quality of sleep at night?
It may have a positive effect, but usually adjustments of deep brain stimulation parameters are driven by positive effects that will be achieved on the control of Parkinsonism, right? And then one would hope, that's why deep brain stimulation is predominantly done. One would hope then that through the improvements of these motor symptoms, one can achieve better night of sleep.
Thanks. And then we received another question asking if you have any thoughts about the use of a weighted blanket, and are there any specific risks to those with Parkinson's?
Yeah, that's an interesting question. We hear this story about stress relieving weighted blankets. That has not been studied, to the best of my knowledge, formally in patients with Parkinson's disease. I do not think that there are substantial risks to it. But what I will point out is that sometimes patients with Parkinson's disease have difficulties with turning in bed, right? They have hard time rolling around. And that may be due to some stiffness, some rigidity that occurs overnight. And in these cases, I recommend patients that they have a bed linens and bed and pajamas, whatever you use, that are more of a satin or a silky material, so that the sliding can be much easier, right? If you need to turn around. And if you put a weighted blanket and have one of those symptoms of stiffness and rigidity, the question is the comfort of turning around at the bedtime. That's the only thing that comes to my mind, why it may be a little bit challenging, depending how heavy that blanket is.
Great. And then back to the question of melatonin, we received another question from an attendee saying, I've been giving my husband 10 milligrams of melatonin. What are your thoughts about that high a dosage?
I don't necessarily have a problem with the 10 milligrams of melatonin. I will tell you that I rarely use the dosages that are above 12 milligrams. This is a well-tolerated medicine, but it can cause some drowsiness in the morning. And some patients, if there are psychiatric comorbidities, if there are cognitive issues, sometimes patients can even have negative cognitive effects, even with melatonin. So I think I have no concerns with 10 milligrams as long as there are no these negative side effects. I think that would be fine.
Great. And then another question. I understand that REM acting out may correlate with increased risk of dementia. Is the relationship likely to be causal? And will reducing REM acting out or reducing sleep apnea or increasing sleep reduce dementia?
Yeah, that's an excellent question. I like all of these questions. So we know that individuals who have Parkinson's disease and coexisting REM sleep behavior disorder may be more prone to develop cognitive problems. Controlling the symptoms of REM sleep behavior disorder itself will not necessarily result in reduction of any risks, because controlling the symptoms, we are really not restoring that circuitry. The symptoms are just manifestations that disease has been present in these areas of the brain that are regulating REM sleep. However, improving a sleep continuity and working to get a good night of sleep and long enough sleep, we know will have a positive effect on cognitive performance and may reduce the chance of a cognitive decline or at least slow the progression of that cognitive decline. So hopefully I dissected this clearly for you guys.
Great. And then another question we have is someone asking, I understood that dreams only occur in REM sleep. With my PD, I dream vividly every night, which I presumed means REM sleep, but I sleep poorly and am tired during the day. Should I presume that vivid dreams do not equal REM sleep, and therefore I'm not getting the benefits of it?
Well, I am glad that you asked this question about dreams, right? I'm going to make a couple comments here. We usually likely all dream, but do not remember. Some of us do not remember our dreams. That's statement number one. Statement number two, not every dreaming means REM sleep behavior disorder. Not every bad dream means REM sleep behavior disorder. Even if you talk in sleep, that may not be REM sleep behavior disorder. So what I'm trying to say is that not everything that sounds and even looks as a REM behavior disorder is REM behavior disorder. So I cannot be more specific about you not sleeping very good, but what I would suggest that you discuss and raise all of these questions about your poor sleep, either with a movement specialist or with a sleep specialist. It is important to point that, because whenever I give a talk, even if I give a talk to medical community, I will always have a number of folks at the end of the talk who comes and tell me, oops, I think I have a REM sleep behavior disorder. We cannot just so lightly jump into that diagnosis, right? So dreams, you know, I have sometimes bad dreams, and I hope I don't have a REM behavior disorder, and I really don't know. So but if I start fighting and start punching my wife in the middle of the night, well, you know, that is really very highly suspicious of REM behavior disorder, right? So these are some things that you can think about.
Thanks. And then could you also answer, how does EDS differ from narcolepsy?
Sure. Excessive daytime sleepiness is one symptom, right? That's a symptom. You are sleepy or you are not sleeping. Narcolepsy is a sleep disorder where excessive sleepiness is the most prominent symptom. And narcolepsy has many other symptoms as well. So I would say that narcolepsy can be one of the causes of a symptom, which is called excessive sleepiness.
And then just the last couple questions here. Will stimulating mental as opposed to physical activity also interfere with good sleep hygiene?
I think that if you stimulate yourself to the point that you start making your calendar for the following day and how you're going to approach that meeting that you have to do, or if you need to meet with someone and what's about to happen the following day, that can very much negatively affect your nighttime sleep. If you are having a soothing mental activity, for example, if you are reading your favorite book, and that can be fantastic, right, for soothing you into sleep. So it really depends on what type of mental activity. In general, I suggest people not to rally up themselves in the late evening hours or before bedtime. You just need to have some soothing, not very much activating activities for a good night to sleep.
Great. And then last question we have here, going back to DBS, is should DBS help with sleep fragmentation?
I think that there are a number of studies that have demonstrated that sleep continuity improves after deep brain stimulation.
Great. And we did just get another question in. Can you distinguish between ordinary sleepy feeling during the day and being slammed with overwhelming fatigue?
Yeah, that's another interesting dynamic, right? There is a fatigue and there is a sleepiness. When we talk about fatigue, we usually think about I really have no energy, right? I am so exhausted, I'm dragging, I have no energy. When we think about sleepy, I really cannot stay asleep. So that means that we will have a patients who are very exhausted, very fatigued, but if you give them opportunity to lay down and fall asleep, there is no chance they can fall asleep. So this is one of the distinguishing possible elements between fatigue and sleepiness. Sometimes very, very hard to differentiate, and sometimes they go hand in hand.
Great. Well, thank you so much for your talk and for sticking around for all those Q&As at the end there. It was a pleasure having you, Dr. Vodenovich, and I hope you and all the attendees learned something from this talk, and you all have a great rest of your day.
Well, thank you very much. Thanks everyone for joining. Reach out to us if we can be of help. And again, many thanks for having me speak today. I really appreciate it. Bye-bye. Be well.
Thank you.